Pepper and Friends, where grit, grace, and wholehearted living come together. And now, here's Dr. Pepper.
Hey there, and welcome into Dr. Pepper and Friends. And today we're beginning a podcast, and we'll probably do 2 or 3 of these, that has to do with the role of medication in mental health. And I have people sometimes that will come to me and they'll ask the question, hey, do you think people are over-medicated in today's day and age? And my answer to that is yes. And then I have people that will come to me and they say, well, do you think that people are under-medicated in today's day and age? And my answer to them is also yes. So there are a lot of myths and there are a lot of assumptions that people make when it comes to psychotropic medication and all of the things that go with mental health medicines, ranging from there's just too many people taking too many drugs, and if you were really, had some real willpower, or if you just prayed harder or you just love Jesus more, then you wouldn't need to take medicine. You wouldn't need all that dope to make you okay. And then I have others that are just so fearful about medication that, there's like side effects and I don't know what I want to put in my body, and they say things like, well, I don't like medicine. Well, of course you don't like medicine. Nobody likes taking medicine. But when it solves the symptoms that you're struggling with, then that's something that helps. So we're going to talk to Keesha Nathaniel, and Keesha is new to the Pratt Clinic, and she's a psychiatric nurse practitioner, and we have 2 tremendous nurse practitioners. Keesha is one of those, and kind of taking a step back is my wife Karen, and she's still here some, but Keesha is kind of our main nurse practitioner now. And one of the things that they have in common is that they both are precepted or supervised by Dr. Kevin Turner, who is an MD psychiatrist who's here in Jackson. That's the role of psychiatric nurse practitioners, is they are functioning as a mid-level clinician with supervision from an MD. And both of them have been with Dr. Turner as their supervisor preceptor for over 12 years now. And he is he's one of the smartest people I know. So I'm hoping to have him on at some point, but we'll see. In the meantime, thank you for joining us for this conversation with Keesha Nathaniel. And just before we get to that, let me remind you about a couple things. One is, if you haven't checked out FIELDCRAFT, check out that if you're a guy or you know a guy. It's really a platform for men at FIELDCRAFTOutdoorCo.com, and I'll leave the link in the show notes below. But it's a platform for guys to just pick up some of the soft skills that goes with dealing with emotions and operating in relationships and caring for their own heart. Okay, so there's some video training. There's a retreat that's going to be coming up, and then there's also some merch. If you want to pick any of that up, you can. So anyway, that's that. And also subscribe. Let us know that you're out there so that we'll know who's listening to us. So thank you so much for tuning in. And we now jump into this conversation with Keesha Nathaniel, who is doctoral level. So she's Dr. Keesha Nathaniel. So we appreciate her being with us. So let's join that conversation now. So we are here with Keesha, and we're this is an introduction of Keesha to the world. Not that you haven't been introduced to the world, but just from the lens of the Pratt Clinic.
Absolutely,
okay, so,
yes.
And we are so grateful that you're here, and it's been fun to get to know you and start to work with you just a little bit. And Keesha is a psychiatric nurse practitioner.
Yes.
And that's not all that you've done. So tell us a little bit about your journey and what got you interested in psychiatric medicine, especially.
Well, I was a registered nurse for several years and had always worked in ICU or the emergency room. And when I decided to go back to school, I wanted to do family nurse practitioner. So I went and completed my master's degree and then started working in primary care, and was like, this may not be for me. So I started teaching a little bit, and someone asked me to do some of their physicals for one of the methadone clinics here, and really enjoyed that. And just started, really connecting with the patients there, really listening to their stories, and, hearing their stories of trauma, hearing their stories of, a lot of times they would say, you know, I didn't choose to be an addict. You know, I heard people say, you know, I ended up on drugs because, you know, I was hearing the voices, I was trying to drown them out. And so it just really intrigued me. And so I wanted to learn more about the brain. And so I decided to go back to school and study psychiatry from a nurse practitioner standpoint.
I think that's such an added benefit to your patients that you've got the general family medicine background and you're bringing that into the room with psychiatric care.
Yes, because it's still a holistic approach. You know, we can't just treat the brain and not treat the rest of the body.
Sometimes people get a little confused about, you know, the difference between counselors, psychologists, psychiatrists, and psychiatric nurse practitioners. I mean, what do you wish people understood about what a psychiatric nurse practitioner is and how you go about your work?
That's a very good question. Psychiatric nurse practitioners are advanced practice registered nurses, which means we have gone back to school. We have completed our master's or our doctorate in nursing practice.
And for the record, you completed your doctoral level.
Yes,
right?
yes, I did. I did go back to school and work on my doctorate and completed. And so when you go back for psychiatric nurse practitioner, you are intensely studying psychiatric care. And so there are some psychiatric nurse practitioners who do therapy. We of course all diagnose any mental health disorders and of course prescribe. I tend to lean more to, instead of doing therapy, I lean more toward the patient education, you know, explaining that, you know, we are working through diagnosing, you know, because you have to understand, you know, I'm sitting meeting with someone for an hour, hour and a half for the first time, and I'm getting as much data as possible. And so, you know, not all the time will you get that first diagnosis head on, but we want to make sure that, you know, we're treating appropriately. So the thing is that I lean more toward the education because I want to educate patients on the diagnosis. I want to educate them on the medications I use. I want to educate them on, you know, like we just said about their health, you know, because a lot of times we have different medical diagnosis that can mimic mental health disorders. You know, you think about your thyroid. You know, some people may have hyperthyroid and they haven't had that checked, and it could mimic mania sometimes. So it's just a matter of, you know, I wish that people would understand that as nurse practitioners, you know, we like to look at the whole picture.
Yeah, I think that's one of the things that I like so much about just that discipline overall. And that's not to slight, you know, the MD folks.
Of course not, because we need them.
Yeah, but,
absolutely.
But I think one of the things that sometimes people get confused about is that, you know, counselors don't prescribe medicine. Psychologists, at least in Tennessee, don't prescribe medication. Right. Psychiatric nurse practitioners, PAs with psychiatric training, and MD psychiatrists are the ones that prescribe medication. But I think one of the things that I love so much about the discipline for psychiatric nurse practitioners is a holistic approach, and it's not just holistic medically, but it's holistically relationally, spiritually, all of those components are added into that. But at the end of the day, you're assessing and getting to know someone in order to consider if a medication may be a proper intervention.
Correct. Yes.
And it's not always. Sometimes there are other interventions that need to come first, but that's the role that you play.
Yes.
Okay. What would you say are some myths sometimes that people may believe about psychiatric medicine, and whether that's something that could help them or not?
A lot of times I hear people say, you know, I don't want to take medicine because then, you know, people are going to think I'm crazy. And so And rightfully so. You know, we live in a society that says, you know, when you have mental health, I don't use the word crazy, first of all. I like to use the term mental health challenge. And we all have those, just to varying degrees. And so I just like to inform people that, you know, it's okay to get help when we're having a challenge. And if it's a mental health challenge, we need to get that help.
Yeah, and it's you know, especially for people of faith, I think sometimes I think we've come a long way in our culture as far as any stigma associated with mental health and with mental health medicine. But sometimes, you know, people get messages from church or they get messages from other places. We just need to pray about that and not take some medicine, you know, not medicate yourself with that.
And you know, my answer to that is, I ask people, I'll ask them, I said, so if you have diabetes and your doctor says, or your nurse practitioner says that you need to take insulin to control your blood sugar, I said, and I would ask them, you know, does that mean you have less faith? And they're like, well, of course not. You know, the Lord can work there. And I said, it's the same way. I said, if a heart surgeon told, you know, if you were having chest pain and it was found that you have heart blockages and you have to undergo some sort of cardiac procedure or open heart surgery, I said, if you undergo those procedures, does that mean you have weak faith? Right. Are you going to pray? Right. Just pray about it?
That's right.
You know? Yeah.
Yeah, and I'll hear people say sometimes, "Oh, I don't like taking medicine." Well, who does? I mean, so please sign me up. I like medicine. Medicine and Skittles for me.
Yeah.
You know, but I take a blood pressure medicine.
Right.
And I felt fine. I had no reason to take it other than my doctor said, you know what? If you have a higher risk of stroke. If you don't take this medicine to keep your blood pressure under control, and maybe he's lying to me. Maybe he just wants to give me medicine just for the sake. But you know, I'm kind of funny. I would prefer not to have a stroke.
Right? You know, absolutely.
And all the life that may come after that.
Yes.
That damage would be done. And I think psychiatric medicine is very similar. You don't have to like taking medicine.
Correct.
But it's also one of those things that sometimes I've seen it work so many different ways, but sometimes the needle just gets moved enough where all of those other things, you know, just kind of lifestyle-wise that they know they need to do, the medicine gives them just enough adjustment that they're able to engage in those healthy behaviors that help them. And then I've seen others where this is like, man, this is the best thing since sliced bread. Why did I not discover this 10 years ago? This has changed my life in a way that some people find it kind of hard to measure at times.
Yes. And, you know, what I would like to say is that, you know, it just depends on the severity of what's going on with you. It depends on how is it affecting your lifestyle, you know, or is it affecting your work? Is it affecting your mood, affecting your relationship at home? Are you not able to enjoy things that you enjoyed before? You know, if you were a person who enjoyed just hanging out with the guys or someone who enjoyed going fishing, you know, what's going on that you're not able to enjoy? Now, on that note, I will say that there are times that medication may not be the first line treatment. You know, for some reason, and I don't know the answer to this, but, you know, people I've come in contact with sometimes is that, you know, if you have a normal human response, it doesn't mean that there's something wrong with you. Like, for instance, this happened a couple of months ago. I was coming down Highland. It was a time that I was supposed to meet with you. Yeah. You know, I was supposed to be meeting with you. And I'm going down Highland, minding my own business. And I hear this big boom in my car. And I'm like, oh my gosh, what happened? Some heart's racing. I'm like, oh my gosh, what's going on? Well, apparently I ran over something in the road. Blew out my tire, blew out the bumper of my car. I'm distraught.
Mm-hmm.
Okay, so that's a normal human response. Okay, so I meet with you, I get to my other appointments, I have to deal with the insurance, I'm stressed, I can't sleep, and then I'm driving down Highland again, this time in a rental car, and all of a sudden I'm having heart palpitations because my brain is thinking, this is going to happen to you again. Okay? That's a normal human response.
Yeah.
Do I need medication? Not at that time. Now, if I was losing sleep, if I were just in a panic, just all throughout the day, I can't work, I
got stuck there.
I can't see patients, then okay, maybe I need to go see someone, you know. There are other times that we don't need medication. You lose a loved one. We have grief. You know, get grief counseling. You know, get grief counseling. Talk to someone, you know. And then, again, it depends on the severity. Now, if I have someone who is so depressed they can't get out of bed, they're having suicidal thoughts, absolutely come and let's talk about, you know, some medications. And I always like to suggest that people stay in therapy because medication and therapy work hand in hand. They work hand in hand.
I remember, probably from graduate school, there was a study, I think it was around cognitive behavioral therapy, but it was kind of the symptoms of depression, and it was over a 16-week period, and they had a control group and a placebo group, and a medication-only group and a therapy-only group, and both group, right? And over a period of 16 weeks, when someone had a depressive episode, everybody got a little better. Okay, in all of those groups, everybody got a little better. But the ones that were taking medication only got better faster. The ones that were in therapy stayed better longer. And the ones that were taking both medicine and therapy got better faster and stayed better longer.
There you go. Right? Absolutely. Because you think about it, I tell people a lot of times, sometimes we can't always just pour out to our family or to our friends because a lot of times they'll say, oh, look at your life. You shouldn't feel that way. Or why are you doing this? You shouldn't be doing this. Well, we need a neutral place to come and just pour out what's going on with us and feel as though we're not being judged and feel as though we're being heard, you know. And so I will always say, start with therapy, you know, as long as we're not to the point of the psychosis, the suicidal thoughts and all that. So,
When somebody's thinking about being evaluated for therapy, for medication, and they've never had that evaluation before, let's talk a little bit about what they can expect, because I think I see some people that come in and they think, okay, well, I'm going to go in and I'm going to talk to this person, and they're going to stick a Q-tip in my ear and send it to the lab, and they're going to know exactly what to prescribe, and it's going to solve all of my problems today. So what can they expect to experience when they come in for the evaluation? And let's say they are prescribed medicine, what can they expect in terms of a timeline to begin to see any differences or side effects? How do you educate your patients about that?
Well, first of all, the Q-tip idea would be great. Maybe we can come up with something. I don't know.
And a myth that's kind of out there is there's this genetics test that we can use and know exactly what medicine works best for you. And it doesn't really tell us that. It tells us how people metabolize medicines differently. But what can people expect?
So coming in for, say, the first time, the evaluation is hopefully is a conversation. It's not, just a checkbox, because I want to try to get to know you as best I can in an hour and a half. And so asking questions about your family history, asking about your, substance use, asking about, and of course in there, we're also talking about your symptoms and so forth. And then there are little check marks that, we do have to do, but hopefully that's picked up in the conversation. And so the other part to that is a lot of times people will come in and they're complaining about depression, but I think a good clinician is going to assess you for other instead of just focusing in on the depression. And so, and hopefully that I can, talk to them about, medication, what our choices are, and why I've chosen those particular medications, and go over the fact of, how those medications work, what the benefits are, depending on which category of medications we're deciding on. I would talk to them about, again, what the benefits are. And most antidepressants, we're looking at 6 to 8 weeks. And I have a lot of people who gasp because I've been suffering for years. I've been suffering.
It was a big deal for me to come here. Get me fixed tomorrow.
You're right, because that's the society we live in. We live in a society that says, stick me in a microwave and pop me out better.
That's right.
So it doesn't work that way. And so that's one of the main concerns that patients do express. So I do explain to them, I do understand that you want to be better yesterday. I do understand that you want to have the energy to get out of bed, to interact with your children, to interact with your loved ones. But unfortunately, these are the medications we have, and so but this is going to take time. We want to, maximize, the medication, especially if you're not having any side effects. Now, a lot of times, especially with the antidepressants, some of the side effects that you can have, a lot of the times is the nausea or the headaches. And that's usually because your body is getting accustomed to that neurotransmitter, the serotonin. And so usually I tell patients, if you can stick with that for at least anywhere from 7 to 10 days, if you could just push through that, it gets better. It gets better. And you would eventually start seeing the benefits the 6 to 8 weeks. But when we're looking at, say, mood stabilizers or antipsychotics, you're usually looking at 5 to 10 days, you can start seeing the difference with those type of medications.
And sometimes we'll hear clients will say, I took this for 3 or 4 weeks and I just feel weird. I feel like I'm out of my personality or out of my body. And the thing I try to explain to them is talk to your provider about that. Okay? Because as much as we'd like to have that Q-tip we send to the lab and it tells us exactly what it is, sometimes it just may not be the best fit for your body, and everybody's body's different.
And the other part is, depending on, if I can get them to use their words about what weird is, sometimes we can change the time of day you're taking it,
I've seen even just like changing from a name brand to a generic or vice versa.
Absolutely. Yeah.
And the solution is not, well, that didn't work, and then you stop taking the medicine. You talk to your prescriber about it so that it can be a better fit.
And so, and I'm hoping that, being here, because being in private practice is a little different than where the different areas I've worked in. So I'm hoping that, patients will communicate with me through the portal, that leave me messages if there are any issues. So that's what I'm hoping will happen, especially being in a different practice setting.
So last question. When somebody comes to you and walks away, what is your dream, your hope that they experience moving forward? Not just their impression of you, but what do you hope they experience in their life differently?
That they've been heard. That they've been heard, because first of all, you have to understand that when a person has decided that that they're going to seek mental health care, that's a vulnerable state for someone, you know, and you don't know if what kind of flack they're getting from friends or family. So I hope that when they leave, they feel as though they've been heard and that they've had some compassionate care for once in their life, and to understand that they are not beyond healing, they're not beyond hope. Mhm.
Well, thank you very much for doing this with us, and I'm even more grateful that you're available to all of our community.
Well, thank you for giving me this opportunity. And I have to share this with you is that I wrote this prayer out in October 2018. And I just asked the Lord, you know, I can't even remember what was going on in my life at that time, but wrote out a prayer. And I just said, Lord, I want to be able to do mental health in faith-based. I thought he was going to send me on mission trips. Yeah. I had no idea.
Well, that still may happen.
Well, I had no idea that this opportunity would be available, 6-7 years later. So, yeah. So I'm glad to be here.
Well, me too.
Yeah,
well, thank you for joining us.
Well, thank you. Thank you.
Hey, thank you and welcome back. And Keesha, such a rich conversation that we have from you today. I'm so grateful that you're here with us. And if you want to schedule with Keesha, if you know somebody that may need to have some evaluation with their medication, you can do so at the link below, or just go to thepratclinic.com and click request appointment, and then you'll select her name from the list of those that are offered as providers. And remember, she's the person that evaluates for medication. She can prescribe medication, and there may be times that she just says, you know what, I think you need other things first. And it may be that medication is not really the first line of defense with that. So I'm so grateful that you tuned in. And stay tuned for more on Dr. Pepper and Friends, where grit and grace come together for wholehearted living.